All right, so it is 12:30, so we're going to go ahead and start. Welcome to the South Texas Regional Family Medicine Grand Rounds. Our educational partner, I'll take that, is the South Central Area Health Education Center, AHEC. Our department's mission statement is inventing a healthier future for families and communities in San Antonio, South Texas, and beyond through excellence in patient-centered care, research, and education. All right. Today is August 30th. Today is August 30th. Don't forget to register your attendance and claim credit. The activity code today is 10093212. We do track attendance and credit via the CME credit via text system. If you have not registered, you can text your email address to the number 844-502-1338 and then text attend and that eight-digit code above. You must register for each session by midnight in order to receive CME credit. This slide just shows you some steps if you'd like to log in and then also track your CMEs. Again, the activity code for today is 10093212. To pull your CME transcripts from the UT CME's office website, there are instructions on this slide. You can just visit their website, log in, place the cursor over My CMEs, and then follow the instructions. You can also claim credit for this event via the AAFP's credit system. You can use the link on the slide. It's that you can just search AAFP credit claiming. This live activity, the South Texas Regional Family Medicine Grand Rounds, has been reviewed and is acceptable for up to 1.0 prescribed credits by the AAFP, and physicians should only claim credit commensurate with the extent of their participation in the activity. And if you have any questions regarding your AAFP CME credits, you can contact the AAFP. The Family and Community Medicine Grand Rounds address nationally established physician core competencies, the Institute of Medicine core competencies, the ABMS and ACGME competencies, and the AAMC competencies on the slide. Conflict of interest statement: Roxana Delgado, PhD, Byron Hepburn, MD, and Micah Wright, PhD, have no financial relationships with ineligible companies to disclose. And at this time, we'll have one of our PGY senior residents introduce our speakers today. Dr. Kristen Kennedy. Yes, go ahead.
Hi, everyone. Welcome to our Grand Rounds. On behalf of the South Texas Regional Family Medicine Grand Rounds, it's my pleasure to welcome Dr. Byron Hepburn, Dr. Roxana Delgado, and Dr. Micah Wright. So a little bit about our speakers. Dr. Hepburn is the Associate Vice President and inaugural Director of the Military Health Institute at UT Health San Antonio. He's also a faculty member in the Department of Family and Community Medicine and the Assistant Dean for Military Health. Dr. Hepburn has a very distinguished military career spanning 38 years and is dedicated to the health and well-being of not only military, but the San Antonio community at large, with a focus on prevention and the social determinants of health. Dr. Roxana Delgado is a professor and scholar in military research at the University of Texas Health San Antonio School of Nursing and one of the investigators at the VA Elizabeth Dole Center of Excellence for Veteran and Caregiver Research. She's a health scientist and epidemiologist with extensive military medical research experience before her transition to academia, and her goal is to dedicate her life and profession to contributing to science and helping wounded, ill, and injured veterans and their caregivers discover ways to thrive. Dr. Micah Wright is a Marine Corps veteran and a Purple Heart recipient. After leaving the Marine Corps, he received his MA in Rhetoric and Composition from Texas State University and PhD from UT San Antonio. Micah has created veteran success programs at different universities. And with that, I will turn it over to Dr. Hepburn.
Thank you so much. Before we get started, how many of you have family members that were in the military or are still in the military? So we've got a number of you, and I know we have one of our faculty here that are in the military. So have any of you personally served in the military? Okay, but we're going to tell you why in a few minutes this topic is very relevant. to all of you, to everybody in this room. You're going, boy, I'm just starting my residency. Why am I even talking about this stuff? Well, you're in Military City, USA. There are a lot of military and veterans and their families here in this area for no reason alone. But we're going to tell you why in a broader sense here very quickly, no matter where you end up in your professional journeys as family physicians. So with that said, let's get started. What we're going to do, if I could get these slides to move down. Kelsey, it doesn't seem to be advancing. Yeah. Just click over onto it, maybe. Yeah. Oh, okay. Yeah, there we go. Yeah. Well, anyway, what we'll do real quickly is we're going to go over the cultural aspects of the military and the veteran community. And that's really important. As you know, understanding the culture of your patient is so important no matter where you are in the world. So, and then we'll switch over to Dr. Hepburn, and I'll go over some of the unique clinical issues you need to be mindful of in this population. And then we'll wrap it all up with Dr. Delgado, who'll look at, and this is important for all of us as family physicians, is the family dimension to this care. So very important. Now, because the way we're structured, please put your questions in the chat feature, if you would. And for those that are here physically, we can certainly, at the end, we'll have time for dialogue, and we'll stay later too if you have specific questions they'd like to talk about one-on-one. We're more than happy to do that. But with that said, I'm going to turn it over to Dr. Wright to tee us up and to go over the cultural aspects of caring for this population. Okay, Dr. Wright.
Thank you, Dr. Hepburn. Oh, don't break it. Like Dr. Hepburn said, my name is Micah Wright. I'm a Marine Corps veteran. I'm the program manager for the Military Health Institute. And I'm here to talk to you about the military, culture, and our heritage. And you may wonder, why do I need to know this? Well, our military experience and our culture informs us how we live even beyond the military, how we view medical care, how we view healthcare, how we view our own health. So being able to see this will help you support the veterans that you see in your clinic. So if you're looking at the picture right now, I want you to look at all the different pictures. This is just a short representation of those who serve in the military. The first thing that you need to know, the first rule of serving military veterans and their families is not to homogenize them into one group. We are a very diverse culture, a culture within many different cultures. So being able to understand that it's not just one image that you see on TV, that it actually represents more than that is incredibly important. So why is this important? Why listen to me, Dr. Hepburn and Dr. Delgado talk today? Well, when we look at almost 20 million veterans nationwide, and the fact that 1.6 million veterans of those veterans live in Texas, and a larger percentage of that lives in Bexar County, it's really important to listen to this, because it's not an if you see veterans in your clinic or their families, it's when. It's inevitable. You're going to see them. So being able to serve them and have those resources and that knowledge is incredibly important. There are 5.5 million military caregivers that Dr. Delgado will talk about here in a little bit nationwide. Often a forgotten group of our veteran culture, a very important group, especially if you ask my wife, because she has to put up with me, right? But having the caregiver and knowing that caregiver is a part of that team will make sure that veteran receives that health and the caregiver receives the appropriate health to be successful. Now, that picture is really important. That's my Humvee. I was wounded January 19th, 2006. It's a day I will never forget. It was on my third tour, combat tour in Iraq. That picture represents one experience in my life. That one experience, though, informs every part of my life after it. I spent a year at physical therapy. I have had 10 surgeries, and I have arthritis that only gets bad as I go with age. You take on depression, PTSD, and the other experiences that I had in the military, being able to understand those and remember that that experience informs my healthcare and my choices is incredibly important. So military heritage and culture. I'm going to step out from this. I feel weird behind it. So armed service branches. We have different armed services branches. Who can tell me one branch, one armed service branch? Marines is what I like to hear. Army, Air Force, Navy. Don't forget the Coasties, Coast Guard. We got Coast Guard. And then it's important, we have a Space Force. It's a subset of the Air Force, but it is an armed service branch. Each one of these service branches have different missions. Knowing those missions are important. The Army is traditionally a land force. Marines, we're part of the Navy. We don't always admit it, but we are part of the Navy. We're Naval Expeditionary Force. Navy's an international maritime force. Air Force is air superiority. Coast Guard, this one's really important. Coast Guard is typically a national maritime force, but Coast Guard is also deployed overseas in hazardous areas. So don't think that Coast Guard, just because of their one role, may not see combat or have that experience. Demographics. Service members, current service members, about 2.1 million service members. Average age between 29 and 30. So you're kind of getting an idea of who you're going to see, and their level of education is bachelor's or higher is 24%, meaning the majority has less than a bachelor's degree. This is going to be represented sometimes by officer versus enlisted. Ethnicity, something very important for our area, is 16.6 Hispanic or Latino. That's incredibly important because a large subset of that population lives here in South Texas and in Bexar County. Recognizing that their culture exists at the same time as the military culture is incredibly important. Since 2001 to 2015, 2.7 million service members deployed on 5.4 million deployments. That is a lot of deployment. That's just 2015. Since 2015, we've probably had the same number. Everybody remember the Afghanistan withdrawal? That was a hard time, right? A deployment, an experience that a service member has that's going to affect their perception, affect how they interact with people, especially in healthcare. Demographic data. We have many different eras of veterans. Right now, the largest demographic is your OIF, Operation Iraqi Freedom, and Operation Enduring Freedom. You're going to see younger people, younger veterans most of the time. However, there's an aging population. We have very few World War II veterans left, but they're still alive. Korean, they're starting to fade out a little bit. Vietnam, that's the next Korea. And recognizing that each group is going to get older and age, and a new subset of veterans is going to come in is really important. If you look at that map of Texas, you'll see that one of the most important areas, one of the darkest areas there, is Bexar County and the areas surrounding Bexar County. Harris County is the other one, but something that's not really represented as you go south is that down towards the valley, there are quite a few veterans who live in rural areas who don't have the same access to healthcare, right? And may not have the same desire to even seek out healthcare because of their own culture and because of the military culture. Recognizing that's important. All right, so military heritage. It's our history, it's our beliefs, it's our culture. Understanding that military heritage is born through conflict is incredibly important. What does that mean? Well, when I joined the Marines, not only did I had to learn how to shoot, I had to learn how to fight, I had to learn how to do medical saving procedures, basic procedures, but I also had to learn my history and my heritage. That defines the legacy that I'm a part of. And that legacy is incredibly important. If you ever want to make a Marine mad, mention something bad about Chesty Pooler. That would make us very upset. If we look at the different things on there, different pictures on this slide, you'll see the different heritage that makes up the military. For me, one of them is from World War I, where the Germans called us Teufelhunden, or devil dogs. To this day, if I'm walking down the street and I see another Marine, whether I've met him or not, he will call me a devil dog. That's part of our heritage. Knowing that affects our language, affects our perception of how we see things and others. It impacts our perception as well. Operational environments. This is important for healthcare, and Dr. Hepburn is going to talk about this as well, because with 5.4 million deployments over 15 years, you go to a bunch of different places. I know right now we think of one deployment area as the desert, right? Or the mountains of Afghanistan, because that is a major part of it. But something to know is that beyond those wars, there are always military deployed everywhere in the world. And the environments that they experience are austere. There's biological hazards, chemical hazards, environmental hazards, jungle, ocean, extreme heat. All of those hazards affect their healthcare for the rest of their life. One thing to think about with this is that the PACT Act was just created. That has to do with exposure, and the exposures that OIF veterans, OEF, Operation Iraqi Freedom, Operation Enduring Freedom, had during their time in deployment. Military rank and chain of command. Now, if you're not in the military, this may not seem as important. Why do I need to know rank and chain of command? It's funny, as I was actually just talking to Dr. Delgado about my final rank when I left the Marines. I was a corporal. I was an E4. I was pretty young. But one thing I told her is that when I became a corporal, I received what's called the blood stripe. That's only given to non-commissioned officers and officers in the Marine Corps. That's incredibly a part of me. That's incredibly important. That's who I am. I love calling USAA, for example, because they still call me Corporal Wright every single time. That rank is going to be different for each branch. Even if it is a lance corporal, their rank is going to be important to them. If you look at this slide, you're going to see ranks from the different six armed service branches of E9. They all look completely different, and they are not called the same thing. Now, I'm not telling you to go out and memorize all of military rank, but if somebody comes up to you and says, "My name is General Hepburn," recognize that that means something. Not just socially, but it means something to them as well. There's a mindset in the military, and it's based on the standards that we live by, the standards that we have for ourselves, and the standards that we have for the mission that we're trying to accomplish. It's unifying. We have a unit, unifying the individuals. You will see in healthcare, and I have to admit that I've been this patient once, I don't want to go see the doctor because other people may need to see the doctor more than I do. I want that sacrifice for the team is important to me. Mission first. I want to know that I can accomplish whatever mission I have. In the military, this is important because a lot of service members won't go see medical, pilots, infantry, because they don't want to be called limited duty, taking them away from the mission that they're trying to accomplish. Adhere to strict standards. This picture on this slide is of a silent drill team. You see they all look exactly the same. When I was in the Marine Corps, we had what's called uniform inspections, stand at attention, stand in formation, and they would come, our first sergeant would come, our sergeant major would come and look at all of our uniforms. The tiny mistake on the uniform would take up our weekend leave. We'd have to stay and work on our uniforms. That's how important it is. And if you think it's just trying to look the same, something that my sergeant major reminded me when I messed up on my uniform is that people in the military, our legacy, people who have died, who have worn that uniform. It's incredibly important. Those standards, being battle ready, is really important. Language and communication. So I'm not going to play this video who's ever seen Good Morning Vietnam? Really? Really? I thought it was going to be the best example. Good. One person, right? So we all have different signifiers. We're all called different things. You're not going to call me a soldier without me correcting you and saying, I'm a Marine. Same thing, they're airmen, Coast Guardsmen, Guardians, or Space Force. Recognizing that title may seem trivial, but it's important. There's varying levels of formality. What I mean by that, and I'm not going to show you, is that when you're around a bunch of non-NCOs that are in the infantry, they're going to be talking differently than the higher chain of command. There's going to be a little bit less formality in the language and maybe some curse words thrown in there. So understanding that is important. Military-specific terminology is something else to think of. If you don't know something, just ask what it is. If you ever come to an MHI meeting, especially for meeting with military, there are so many acronyms thrown around, it's not even funny. And the line from Vietnam is, excuse me, sir, seeing how the VP is such a VIP, shouldn't we keep the PC on the QT? Because of the leaks to the VC, he could end up in MIA and we'd all be put on KP. Now, those aren't all military terms, but you get the point. We speak in this weird language sometimes where things are shortened. You may have no idea what it is. Just ask. Oh, there you go. So this is my last slide, and this is important because this is our biggest population right now. War and sacrifice in the post 9/11 era, we're seeing a lot of effects from, and we're really trying to make sure that we're addressing it and we're trying to help veterans transition. 44% of post 9/11 veterans, anybody who joined the service after 9/11, stated some difficulty transitioning to civilian life. Now, this doesn't mean PTSD. That's what everybody thinks when they hear this. This just means the shift from the military to civilian life, the loss of culture, the loss of identity, the loss of purpose, loss of a mission, loss of brothers and sisters in arms is important. It affects them. I've been out since 2006. Things I miss about the military still exist today. 38.1% of post 9/11 veterans have a service-connected disability of 70% or higher. Dr. Hepburn is going to talk about the different disabilities that you'll see, but that's something to think about. 70% disabled or higher. That means the medical needs of those service members and those veterans and those caregivers are going to be something important to understand. Here's one that breaks my heart, telling anybody. 16.8 veterans, this is from the VA, died by suicide each day in 2020. That's 6,146 total veteran suicides. Now, as somebody who serves veterans and serves the military, that number is tattooed in my brain every single day. Here's the scariest thing. 60.3% of those numbers were without recent VA healthcare encounters. That means 40% had seen a doctor, some sort of medical professional, yet they still ended up as a statistic on here. That means you as care providers have the opportunity to interact with somebody and help them find that transition, help them find that mission, that purpose, or the resource that's needed to help serve them. I'm going to go ahead and turn it over to Dr. Hepburn, who's going to talk about caring for the military veteran patient.
So the key takeaway from what Dr. Wright just said was, when you're in clinic and you see, it might not even be an elderly person wearing a hat, says Vietnam vet or something, take the 30 seconds to get a little background on him and celebrate that. And it's important to him or her and their family. But talk about some other things too. But let me back up. As a family physician in the Air Force, I think we don't want to cloud this in a negative way. We want to be objective. Most military members and their family find the experience very positive. It's a very rewarding experience. They grow and their families grow professionally, and it's an honor to take care of them and celebrate that. And you as family physicians, there ought to be a great joy, even in taking care of a wounded warrior and his family. There ought to be a lot of, and there will be a lot of professional satisfaction taking care of those men and women. When I was a young family physician, I was taking care of World War II vets, guys that had been on the Bataan Death March or had checked out of aircraft and bombers and so forth. That it was a privilege to take care of those men and women. So view it from that perspective. But it's really important to underscore everything that Dr. Wright just said as you move forward in your care. This is so important. History is always important for all our patients. You know that. But in this population, you need to take the time, or if you're in private practice with your RN or your intake team, make sure they're taking the few extra minutes to do a detailed history on where they've been militarily, the exposures they've had, any surgeries they've had, or injuries and illnesses they've had. It's very, very important, okay? And Dr. Wright touched on the PACT Act a few minutes ago about the exposures. We'll talk about that here in a second. And then certainly, like you do on all our patients, do a good medication reconciliation. And also make sure once you gain that therapeutic alliance with them and that trust over time, they'll confide in you in substance use, which is unfortunately pretty prevalent, particularly with people with chronic pain. So gain that trust, that alliance as you're moving forward in your care for these men and women and their families. Mike already spoke to this, but each one of those operations had a different set of circumstances. So the Marines that were up in Korea in the middle of the winter back in the 50s have a different shared experience, obviously, than the men and women that were in Afghanistan in the mountains there. Okay, so be mindful of that. And certainly you guys and gals are reading about what's going on in Ukraine right now. So a very different urban warfare type of environment and very austere conditions. So be mindful of that. And what you'll be seeing probably too, segue to this discussion right now, but don't forget, women and children, families are impacted by war. So we have a number of the immigrants here in San Antonio that you'll have the honor of caring for too, that fill into this discussion as well. Okay? Now, you also hear the military term, use these terms, combat injured, wounded in action, that type of thing, versus non-combat injuries. You don't need to know about that. But be mindful that there are consequences of conflict. We see it here in San Antonio, unfortunately. Blunt trauma, penetrating trauma, explosive injuries. And all those create certain injury patterns, physical and emotional. And be mindful of those things. The big ones, obviously, you're going to see those that have been in conflict, burns, musculoskeletal injuries, infectious disease consequences, and certainly anything of that consequence. When you're talking about a polytrauma, there's going to be an emotional piece to that. You cannot experience something like that. You know that without an emotional element to that. And you be mindful of all that. So, and unfortunately, you're reading about it. The nature of weaponry is only getting more severe in the years ahead. Today, we're seeing what's called hypersonic weapons. We're seeing thermobaric weapons where the explosion occurs above a formation. Horrific. We're seeing in some of these Ukrainians with very severe burns. So hopefully you'll never see that, but you may see the downstream effects of that burn care for that patient in the years ahead. All right. Dr. Wright already foot-stomped this point, but this is a study from the Institute of Medicine that we have to be mindful of those injuries that those young men and women experience in their 20s as they get older are only going to be amplified. We already see this in some conditions, post-polio syndrome. When their immune system starts dropping off, it comes back up. So this is the military equivalent of that. Okay. So a person that has had severe trauma, we're already seeing this, and I'll talk about it in a minute. TBI, multiple concussive injuries. They are coming into our Alzheimer's clinic at the university in their 40s. And that we should be seeing those guys and gals in their 70s. You know, so it's an insult to the brain early on, and we have to be mindful that you have to have a higher vigilant to those conditions. Well, heck, this guy, he's only in his 30s. Well, I'm not going to be worried about ALS. It'd be very unusual, but you have to be thinking proactively about those things clinically. Okay. Now, these are disabilities that the VA sees. And what does that mean? Well, look, these are common conditions that you'll see. Tinnitus, somebody that's been exposed to a lot of noise. I was a former pilot around jet engines a lot. And so, somebody like Dr. Wright, who was around explosive devices a lot, they certainly have that. And certainly musculoskeletal injuries, a lot of those, obviously, and the neurologic conditions as well. Now, how many of you have already heard in the hidden injuries of war? But these have a lot of applicability for us in clinical practice for non-uniform patients too. Certainly, I know for a fact you'll get exposure to in your residency here on sports concussive injuries. I mean, you've already had some lectures on it, I don't know, but I know they give them here, and it's very important you understand that as a family physician. But that's the medical equivalent of that traumatic brain injury. And then certainly Dr. Obeid and her team, the behavioral health team, is going to talk to you about traumatic stress and post-traumatic stress. It has certainly applicability in a lot of the patients we see here at the Robert Greene too. Okay, but this is combat related usually. So I'm not going to go over all the details on the traumatic brain injury slide here, but I want to foot stomp one thing, and that's the mild. Just because it says mild, don't discount it. We see that in soccer players, boxers, whatever. Repetitive trauma can cause serious implications downstream. Okay, so a young Marine that has had multiple mild insults, blasts, injuries over time, it's cumulative. It's kind of like what you see with some of our elderly patients here with multi-infarct dementia, multiple strokes impacting the cranial function. But obviously, the more severe ones, moderate, and Roxana, Dr. Delgado can speak firsthand with Victor, her husband, of more moderate and severe, the implications of that, with the multiple providers that are needed to care for somebody like that. And I don't know if you, do our residents rotate at the VA at all? Do we? But the VA, okay, if you have the honor of doing it, go to the Polytrauma Center and see some of those patients that are there, either from combat or from a major accident on the interstate or whatever. But it'll be important to understand that population. And again, most of them are mild, but again, don't blow it off, if you want to call it that. All right, now PTSD, and you're going to get lectures on this, so I won't belabor the point, but it can be many times it's due to non-combat insults and assaults. And I'll say this. Let me back up. A lot of men and women, they're coming out of the general population before they put the uniform on. They, in their youth, have already experienced some degree of trauma for many of them. Okay, so they're going in there, at their baseline may have already been somewhat tenuous in some regards. And then you throw them into a cauldron like Afghanistan or Iraq, and it can only be more amplified. So be mindful of those things, and the criteria. I know Dr. Obeid and Dr. Hero Johnson will go over those things with you, but these are all linked up. All these slides are linked, so you can get to do a deeper dive when you have a few minutes. Now, we have a screen, and I know they have it here. And we certainly have our depressive screens that we use in EPIC, but certainly we have also CBT exposure therapies. Some clinics in town use the eye movement disorder clinic, and be mindful that the SSRIs are very helpful in these patients as adjuncts. Don't ever use them alone. Don't just prescribe a medication without doing the behavioral health component to it. In fact, what I would do in practice is make sure you do the behavioral health first, okay? And let me foot stomp one other thing. You've got to have a therapeutic alliance with these patients. As Dr. Wright mentioned, if they are stoic, they're usually not going to bring these things up. It's going to take several visits before they're comfortable in talking to you about some of these things. Okay, and I know that firsthand, having been an Air Force doctor. Now, okay, we talked a little bit about the PACT Act, which is an acronym, and but it's just passed this past January, but it's basically for toxin exposure. So the VA now is recognizing these toxin exposures that our men and women have been experienced really are significant. And really, whether they be chemicals, like the Vietnam vets, have you read about Agent Orange in Vietnam? Okay. So the dioxins, they actually sprayed the forests, the jungles, to defoliate those jungles with this very toxic substance. And the men and women were walking through those jungles, and the men and crew members on the aircraft were exposed to those as very, very toxic agents. I know for a fact that having been there in the Middle East, the oil well fires in Kuwait and so forth, breathing in day in and day out those fumes, or we had the burn pits. So maybe they burned a lot of the trash, but they threw everything in those trash pits, and the men and women were breathing in this toxic air for a long period of times. Now, those last couple things, I pray to the good Lord that we never see chemical or biological weapons used, but we do have, I mean, so, in Syria, they've used chemical weapons against their own people. So it's not out of the question that we may have to deal with those kind of patients as well. So be mindful of that as well. Now, infectious disease. This is really important for a family physician. We're a culture where people travel. I'm getting ready to go on a plane here, hopefully in a couple of weeks, and head over to Europe, but I'm not going to West Africa. But we do have family members, and we probably have we do have a lot of citizens here in San Antonio. They go on mission trips and what have you. And so we want them to do that. But you have to be, when you have, and I'm looking at a guardsman right here. So when Dr. Fortune deploys on a humanitarian mission to Liberia, and he comes back and he's got aches and pains and he's got fever, and Dr. Hepburn sees him, I better know that he just came back from Liberia. You guys are all shaking your head, right? Because what is it here in San Antonio? It's a viral URI. What the heck? Take some Tylenol and call me in the morning if you're not feeling better. That's the wrong answer for a Marine, which happened in Liberia. Because every minute you wait to treat that guy or gal for the malaria is putting him at greater risk of not making it. And then it becomes cerebral malaria. So be mindful. This is why you have to know the patient. Oh yeah, Dr. Fortune, or Joe, he's a guardsman with the Texas Guard here in Abilene, wherever you end up practicing. And his whole unit just went over to Liberia for a humanitarian mission. God, how'd you guys do? It was great. Oh, but Doc, I've been having a fever and da-da-da. So then you have to have a higher index of suspicion. Those are common conditions below there that you also need to be worried about too. The slides there of, this is a board question for you guys from med school. You remember leishmaniasis? Okay, you're all shaking your heads. Sandfly fever. Okay. When I was in med school, I was going, we're never going to see that. I mean, but heck, why is that important? It's not just the cutaneous lesions; it can become visceral and life-threatening. So don't trivialize these things. Be aware of them, and be keeping your aperture open and wide when you're dealing with those patients. That's why I want to bring that up. Now, I don't want to finish up on a negative note, but it's a reality note, okay, for all of us. And we know that for our patients here at the Robert Greene too. And don't forget too, when we talk about sexual trauma, we're talking about men too, unfortunately, as well as women. Okay, so keep that in your differential. When you see somebody you can't put your fingers on the anxiety or depression or their social isolation or their dysfunctional behavior. She's a personality disorder person. Well, wait a minute, why? Sort that out with Dr. Obide and Dr. Hira Johnson. Okay. And it's the same thing for the military. The military has put a great focus on this, but it's a reflection of our society, unfortunately, that we have to be mindful of it. Okay. And you can do your part in mitigating that impact in your care for these patients. So the takeaway from my piece is it should be a joy and an honor to take care of these patients. You should grow professionally from them, learn from them. You will learn more than you give them, really, in many cases, and their families, what their journey, and you'll be better for it. But don't forget to reach out to us in the years ahead if you have questions about how to best care for them. At the end of this, we have some good links for you. But now I want to segue to something that's really important for you as family physicians. is the family dimension of this care, the spouse or significant other dimension, and the extended family, okay? And then we'll have some time for Q&A, okay? All right, over to Dr. Delgado.
Thank you, Dr. Hepburn. So I don't take this for granted, and I'll tell you why. It is very unlikely that you're going to be exposed to having a general who happens to be a physician, a combat wounded veteran, Marine, and the spouse of a combat wounded veteran all at the same time working in healthcare. It is very, very unlikely that you're going to be exposed to this every day. And for me, it's an honor to be presenting along with them. So my name is Roxana Delgado. I'm a professor at the School of Nursing. And like Dr. Hepburn mentioned, I'm the spouse of a combat wounded veteran. He was wounded in June 29th, 2009. And that shifted my entire career. By then I was already an epidemiologist, but then, you know, it just happens that I started seeing the personal lived experience of the family members and getting that call. My call came in at 4 a.m. on the 29th. And basically they don't say too much. They're like, are you in a safe place? And I'm like, yeah, I'm not in town. I'm actually doing researching for Carson at that time. And they said, well, we regret to inform you that your husband was wounded in action. And then after that, you don't hear much. So there's a lot of anxiety that goes with it, a lot of unknowns. So then, but that's just the start of a very different journey in my life. My husband was medevac, or medically evacuated. This is where the acronym starts sometimes. He was medically evacuated, 3 years of full-time rehab. That was 14 years ago. So I'm very, very proud to say that he's completely independent. He lives a full life. We were just talking about him earlier. He runs a nonprofit. So he's very active here in San Antonio. But that's what we want veterans to be when they come back home with all these injuries. We want them to be successful. We want them to put them in that path of independence, and you can make that happen. His best advocate is actually at the polytrauma at the VA. So those of you who are going to be going through the VA, or you see Dr. Tapia, that's his champion. So you tell her that I gave her a shout out here. So when we think about a family member, so caregivers, we have 53 million caregivers in the nation. 5.5 are wounded, are caregivers caring for wounded, ill, and injured veterans. Dr. Wright talked about the different eras. So 20% are OIF, OEF, so those who are post 9/11, and the rest are all our aging population, some other eras before the 9/11. And one of the distinctions, because I get this question every time I go to a conference, what makes military and veteran caregivers so important or special? And I wouldn't say that they're more special than any other caregiver, but why we need to have kind of like that extra awareness and be sensitive to them. When you look at these studies, they reveal that a military and veteran caregiver, they are caring for a veteran or assisting for not just one condition, like diabetes or dementia. They're caring in average for 4 different conditions that are not correlated. So they may be an amputation, burns, traumatic brain injury, PTSD, chronic pain. So that, and Dr. Hepburn made note of this. At some point in time, my husband was seeing 28 different specialists. I have to work with 28 different people telling me a lot of different things of how to take care of him. And then with that comes the medications and the care management and the care coordination. I mean, it is very, very complex. So military and veteran caregivers is not per se because they're married or are parents or children of combat wounded or wounded, ill, and injured. It is because of the characteristics that surrounds them. The other thing too is that when you look at the post 9/11, you're gonna see that the caregivers on average at that time, you know, when the RAND report came out, and you're gonna see that book there, that is free. If you go to the link or if you go to that citation, you're gonna be able to download the 232 pages, and at your leisure, you can just read it over a cup of coffee. I have done several times, but you're gonna learn so much about this population. This is the only population study that have been done, and there's supposed to be coming out a RAND report very soon in the next couple months, and you're gonna be able to see what are the updates when it comes to the population, because we have been on this like for 20 years. So one of the things that you're gonna see with our military and veteran caregivers is that not only they're gonna go through activities of daily living, so they have to care physically for these veterans, But we also heard from Dr. Hepburn and Dr. Wright how we have some other conditions that are more behavioral health. Have you ever heard of the term suicide watch or seizure watch? This is what a lot of our family members are standing by, taking care of our veterans in this nation. And I tend to see the caregivers, and I refer to them like this. They're the first line of response to long-term care for our veterans and in our military. They're the ones who, when they come home, they say, you know what, I am here. I'm going to be, so when you may see that patient for 15, 20 minutes, but guess what? We take over and we're 24/7 later on. So it is really nice to form that partnership. I personally have had that partnership with the healthcare providers, and it's been beautiful because we're able to work with the veteran in a way that they adhere to the treatment plan, but at the same time, they're able to, you build that trust with them. We know that caregiving can have, and we have heard this, and even with yourselves as caregivers, professional caregivers, there's an emotional toll, physical toll, but in our family members, we see also social and financial challenges. So it's not just that physical ailments and toll of caring for someone physically, but it's also that psychosocial impact. And when you see a family member walking in with the veteran, I would encourage you to also look at her or him, that caregiver, and say, hey, how are you doing today? Acknowledge them. You will be very surprised how much that encounter or that question can really mean to their life, and how much you can leverage from that relationship that you can build with that person. So we see the psychosocial component of caregiving, and how much it impacts the not only the person but the family. When we think about the post 9/11, those are younger, so you're going to have the children involved. There's a new program called they're referred to the hidden helpers, because we have children who are actually caring for wounded and injured veterans. And believe it or not, some of them are trained to keep daddy or mommy from dying by suicide, which is, I know it sounds sad, but it's something that is a reality in our community. So our work started with looking at the health and well-being and the trajectory of health and caregiving. And one of the studies that we conducted, we included a piece on suicide ideation in our caregiver community, because we know a lot about the veterans. And anecdotally, we have heard caregivers, and we have seen it in our community. I personally have known 6 that have died by suicide. And I said that this is too high for just one person to know. So Congress really wanted to work on some programs along with the veterans to have caregiver suicide prevention, but we don't have numbers. So at UT Health, we are the first working on a seminal work, and we publish, and we look at the suicidality or suicide ideation in the caregiver community. And it came out to be, in a sample of 500, we had 24% saying, yes, I have considered, I have planned, or attempted suicide since becoming a caregiver. So our work has been inspiring different policies around the nation, and has been included as part of the National Veteran Prevention Program. So you're gonna see there's a slide that has the study, so you can look at it later. It's open access, so you're more than happy to download it, share it, copy it, read it. If you have any questions, you can always reach out back to me. But one of the things that were very distinct of this study is that we have 3 phenotypes, so 3 groups: low, medium, and high risk of suicide ideation in caregivers, in those who participated. And 20% were in the high risk group. And one of the predictors was caring and assisting a veteran with either traumatic brain injury or having suicidality themselves. So that means that has clinical implications, because that means that when someone walks into your room, or you walking into a room and you see the veteran, and you see that the veteran has a history, try to see if the family member is there and the caregiver is there, and more likely that person has been affected beyond what you can think of. And that's where you're gonna see that next slide. And I don't pretend for you to really see all this, but you can go online and see the caregiver journey map. The most important is that this is the first time that there's some work that has been done into looking at the caregiver journey. So first, identifying themselves as a caregiver. So there's three main phases: becoming aware and adjusting. So remember that call, and it's not always a call. I receive a call, but sometimes it's walking into the ER and getting a new diagnosis, or just an abrupt accident or something that happens. Then the person, the caregiver shift, right? There's a shifting of priorities. We see a lot of caregivers from the post 9/11 leaving school, leaving work, and having to stay caring for the veteran. And then third phase is a rhythm. The thing is that with the veteran community, that rhythm could be short, or could many times is not prolonged, because we're going to have new diseases emerging, and new diagnoses coming in that may be associated with comorbidities to the already existing diseases or illnesses or injuries they have. So if you have the time, just if you ever want to understand what the caregiver journey is, all these different other areas is the challenges and what we call the pain points. So if you are interested, I'm more than happy to walk you through this. And last but not least, but this is a very important initiative that is happening at the VA. And it's a collaborative between UT Health, ourselves, UT Health, the VA, and funded by USAA. And it's called Elizabeth Dole Foundation. So it is called the Campaign for Inclusive Care. You have heard of patient-centered care. Probably you have heard of patient and family-centered care. But one thing that we haven't really nailed down is how do you leverage on the knowledge, the relationship, and the trust of caregivers in the treatment plan of complex care like the ones in the veteran. So we started, it's been a 5-year project, but we are at that point where it has been implemented across the VA. It has trained over 7,000 VA healthcare providers. So if you're at the VA and you ever see this campaign for inclusive care, know that the model, what it is a framework, an approach where it's inviting healthcare providers like yourself and acknowledge the caregiver and include them as part of your treatment plan in terms of, hey, I'm going to prescribe this. Could you help with? Or do you have the capacity for? Or do you have the resources at home? So it's a way where you work, you lock arms, and you work with that family member to make sure that that veteran has the best success they can have. I can tell you that it has been incredible in the couple of years that has been established, and the VA is pioneering all this. It is not yet in the general healthcare field, but we're looking at expanding and having it at a larger area. So with that, that's my part of the talk, and I appreciate very much, and I'm gonna hand it back to Dr. Wright. Thank you.
All right, y'all are stuck with me one more time. So available resources. So there are different types of resources, and I've classified them a little bit different so you can kind of understand the general umbrella that each one is under. The Veterans Administration, the VA, we all know what the VA, it's across the street from us, and the medical center, they have every support that you can think of: healthcare, education, career counseling and support, disability compensation, life insurance, home loans, disability housing grants, caregiver support. Anything that you can think of, the VA has it. You just have to find the right person. I'll say the hard thing about the VA, like any healthcare system, is they're overwhelmed sometimes. So it's important that you have some sort of supplemental resource that can help out. Now, with veteran service organizations, or VSOs, there are about 40,000, over 40,000 nationwide, and some of them overlap. It is impossible to know all of them, but here's some of the big ones. Endeavors, a great organization that we partner with, has the Veterans Wellness Center, and they typically can get a veteran in pretty quick, and a caregiver to talk to them. Wounded Warrior Project, they have education benefits. They have resume and workplace assistance. They have counseling, anything that you can think of. Semper Fi Fund, which is now called America's Fund. Warrior Reunion Project. If you're somebody that's missing that camaraderie in the military, the whole point of Warrior Reunion Project is to get their unit back together to find that camaraderie again. The last three, you're going to see a lot of the Korean War veterans, World War II veterans, Vietnam veterans, Veteran of Foreign Wars, VFW, Disabled American Veterans, DAV, and Purple Heart Association. Something to remember about most of these is that they all have healthcare advocacy. So if you find somebody, a veteran or a caregiver, who's having a hard time getting an appointment at the VA, any one of these organizations will help them do that. And it's pretty easy to connect them there. City, state, and federal veteran organizations. So the VA is the federal organization, but our city and our state they help veterans get land and housing grants, disability grants, anything that you can think of. Again, the Military Veteran Peer Network is supported by Texas Human Services. Almost every county has a military veteran peer, a coordinator that is running, and they're social workers. They coordinate care and advocate for healthcare for them. Here in San Antonio, we have Alamo Area Council of Governments, Bexar County Military and Veteran Services, City of San Antonio Military and Veteran Affairs Department, and something that you wouldn't think would be important, but it is Bexar County Veterans Treatment Court. You find somebody that is having a hard time, maybe they have a record or they've been getting in trouble with the law, knowing that the Bexar County Veterans Treatment Court can be that program that pushes them in the right direction. All right, it's been awesome talking with y'all today. I'm going to let Dr. Hepburn come up and finish. We just have a 50 multiple choice questions for a quiz.
No, we just have a few minutes left, so we do have softball questions, but I think I'm going to pump the brakes on those because I want to give you a few minutes to ask any questions. I want to foot stomp a couple of things that Dr. Delgado said, though, when you're in clinic. She touched on the caregiver. Sometimes it's the older children that are the caregiver. And what I've seen also, particularly because of a lot of our men and women that go into uniform, they're only 18 years old. They're right out of high school. It's the parents, the elderly parents or grandparents that are the caregivers. So when you're seeing a patient here in clinic, most of the patients I see are the pretty senior ones. I have to be mindful that they may be taking care of their grandson who's a wounded Marine, and try to peel all that onion back. So be mindful of that as well. So what questions or comments do you have? I know we have Dr. Belzadou, who's also serving in the Texas Medical Brigade. So in addition to these guys doing their full-time jobs, get them a latte or something someday for spending their weekends serving in uniform too. But it is an honor to take care of these patients. I know you will see them. I'm confident no matter where you go on your journey, you will see these patients and their families and learn from them, grow from them. Reach out to us if you have questions about that, okay? And make sure all these slides, those resources that Dr. Wright spoke to, those are all linked up. So you can pull these slides up from Kelsey, keep them in your e-folder for 5 years from now and say, you know, Dr. Wright mentioned that there is something about some guy that's going to jail. What was that thing called? Veterans Court. Okay, use those resources for your future reference. They're all really, really robust and they have a lot of good information. Okay, what questions do you have? Yeah. So the question, Micah, for civilian transition to work.
That can be mental health. That could be transferring over healthcare. When I had to transfer my healthcare documents from having 10 surgeries and a year of physical therapy, it was a fun ordeal. So having a connection, do that. But sometimes it's financial training or financial assistance, housing assistance. Maybe they're going back to a home that they can't be in anymore because they're disabled and they need some sort of support doing that. So you got to think about the transition as a holistic thing and really asking the patient and getting them, like Dr. Hepburn said, to peel that onion back is the important part of that.
In our university, and to change the subject, but it's related. In just about every one of our schools, we have veterans that are students, or their spouses are, and they're bringing in a wealth of experience. In fact, our university appreciates it because these students have had a lot of real life experience, and they lend a lot to the classes they're with. So it's a good, very positive thing. And so when you go into practice, I am confident you'll have MAs, you'll have RNs, you'll have allied health providers, the PharmDs, the behavioral health that have had some military experience, and they will lend a lot to your practice. And actually, probably you want to seek them out if you're the clinical leader. Okay. All righty. Any other questions or comments? Yes. Yeah. Did you hear the question? How can you let's say you see a patient, you're busy, you got a 15-minute appointment, and red flags are going off left and right on this guy or gal. What are you going to do? And it may take months to get it into a psychiatry appointment. We know that for a fact. You're going to have to, one, do the continuity of care yourself as much as possible, or your colleagues in clinic. You're going to have to leverage the team that you do have, and hopefully you'll always be in a place where you have some allied health professionals too, or at least you have access to, a psychologist and a social worker. And certainly, like Dr. Wright said, fortunately, we're very blessed here in San Antonio. We have a lot of resources that you won't have in Uvalde, or you won't have in rural Texas. So the VA is doing more and more virtual health too, mental health. So those things will be adjuncts too in the future. And I'm sure we'll see more. Look, this iPhone is never going to replace you talking to Dr. Miiiary Johnson. That's not going to ever replace it 100%, but it might give him a 60% plus up. Okay, so leverage those things. Be mindful as things move forward clinically in your practice over the next 30 years or whatever you do. You'll see new adjuncts coming into place. But I would put in your inventory, on your quick dial there, some of these resources so you know how to access them in your busy day, or make sure your teammates, when you're in private practice, your RN or whoever's your senior clinic administrator knows how, hey, you can hand off Sergeant Hepburn to the administrator, say, make sure he gets at least contact with Endeavors or Wounded Warrior Project before he give him the handout for the Wounded Warrior Project, that kind of thing. Does that help? Yeah, you're going to have to brainstorm wherever you end up landing. Here in San Antonio, you've landed in a good spot because we got a really nice team here. And we have a really beautiful city. Dr. Wright.
We had that same issue, that we'd find a veteran that needed help yesterday, but the school counseling was so overwhelmed that it was hard to get them in. I could typically get them into Endeavors, if not that day, within the next couple days. Just like that. If they were in crisis and I told them they were in crisis, they were really good about getting them help right away.
And look, I know Dr. Obaid and Dr. Miiiary Johnson give you lectures on this, but if you have somebody that's in crisis and you're worried about them having real suicidal thoughts, make sure you have those frank discussions before they leave. And if they go AMA, pull the spouse aside, or the family member, and say, make sure the guns are out of the house or locked up. All those things, and you're going to get lectures on this. I'm confident of that because you will see it in your careers. Okay, I pray to God you don't, but I just know from my 30 years in family medicine, you will see it multiple times. Dr. Fortune.
Yeah. So you said active, like current service members. If they're a current service member, they can always go to BAMC here in San Antonio. Anybody that's currently serving, National Guard, whatever, they can go to BAMC, get free health care like that. So if they're in crisis like that, it's the people that have just gotten out or and haven't gotten connected to the VA, or they don't have enough of a disability to get to the VA, or the people that fall through the cracks. And if there is someone like that, and they just need to sooner follow up with us. If you know, I'm not behavioral health, but you can always send me a message, and I'm happy to overbook myself for that.
Yeah. So yeah, I'm glad that portion picked up on that. Yeah. So here's no, but I mean no. So and that's true. If you're still in the military, you get immediate access right away. Yeah, or your family member does too. Now here's the other. You'll see. I don't want to hold you guys up. You got next lecture, but sometimes military members don't want to go to the military provider. They're worried about their career. I'm a pilot. I don't want to lose my flight status. I'm a security forces. I'm a military policeman. I don't want them to take my gun away. Okay. And they may go to you and they may be complaining about back pain, but really they're really thinking about hurting themselves or something. So peel that onion back. Still try to get them over to the military care. They're really, really good about guarding that information, that privileged information. But if they're saying, I'm not going back, then do what Dr. Wright said. Reach out to Endeavors or something as a second best. Dr. Delgado, did you have something you were saying? No, go. Look, I don't want to hold you guys up. This has really been productive for us to be speaking with you, but reach out to us in the months ahead, Dr. Hepburn, and we'll connect you with the smart guys and gals like Dr. Delgado and Dr. Wright to get you the assets you need, okay? But at least keep these files on your e-folder for reference, okay? All right, wish you all well in your studies here. Take care. Bye.